work. Is the microphone working? Oh yeah, there. Okay, so I'd like to talk a bit about shorter-term missions, shorter-term trips, and how we can achieve something in a short time, because many of us are working full-time in our own practices. We only have a little bit of time that we can spend going abroad and trying to make an impact. So I'm going to just go over some of my experiences, talking and contrasting 3 different case studies, and talk about what I've learned during what I've been doing. So I'm an oculoplastic surgeon back home. I run a busy orbital referral service, but I'm also a travel addict. I've loved traveling around 45 different countries, but I'm also an educationalist. So I've studied education and done a master's and wanted to get involved in education around the world. So thinking about why we volunteer to go on these short-term trips, it's nice to think that we're all altruistic. I think most of us going into medicine probably do want to do it for the benefit of others. And in going abroad, we can try and use our skills to help those with more limited healthcare resources, and also those with fewer training resources. We may also develop ourselves, so we may be able to acquire some personal development during these trips, so we can gain experience in teaching and training in different places. It helps to combat burnout when we're doing the same things all day, every day back home. It exposes us to different healthcare systems and cultures, so we might learn something that we can bring back. Then slightly less altruistic motivations, we get travel experience. We might experience rarer cases that we haven't seen elsewhere, and maybe surgical practice of rarer cases. But some of those, I think we have to examine our own motivations for why we're doing it. We may also be motivated by a specific invitational purpose, if there's a locally identified need, or perhaps we've been invited by fellow clinicians and societies. So when I first set out to do some volunteering abroad, I think I had a slightly naive model in my mind, thinking we would just go, we would be visiting doctors or specialists, we would treat some patients, and everybody would benefit, and it would be great. I think what I didn't realize initially, though, is how much medical care does not occur in isolation. There's many more things to think about. So social attitudes, there may be different attitudes to what we're used to in our home countries, traditional versus modern healthcare. There may be traditional systems of medicine, and people may have a distrust of our Western or local medical practices, and various social practices may have an impact on patient health. There may be multiple different non-government organizations working in a region, and there may be difficulties in getting funding, there may be competition for funding, and there may be good or bad interactions with other groups in the area. The government of the countries that we're going to may support us, or in some cases they may block, they may not wish outside aid. They may have their own agenda, and particularly in some areas that they may lack an effective public health policy. So if you're going in to try and do some short-term volunteering, the amount of impact that you can make may be limited by the local public health policies. The local doctors may not welcome us with open arms. Sometimes they would love the training, sometimes they welcome the help, but sometimes they might feel threatened by the visitors coming from overseas. Threat of taking their practice, taking their funding. As I've said, there may be traditional healthcare practices that may be preferred by patients and trusted even by doctors, but which may actually be ineffective or harmful. And the country itself may not be stable, so some places have a lack of infrastructure, like Claire said in Uganda, difficulties physically getting the patients to come to the clinics. There may be a lot of corruption. That means that healthcare resources are spent and allocated badly, and there may be war. So my first case study is a trip I made to Cambodia, which is a country in which there's 180,000 blind people, most of which is avoidable or at least treatable, and 75% of that is from cataract. So most of the population is very poor, and there's very few ophthalmologists, particularly because there's this missing generation after the Khmer Rouge genocides. A lot of intellectuals were murdered, and they're only just starting to build up their own population of doctors. So I went as a group of visiting surgeons just for a week, and we were aiming to provide mainly cataract surgery. There was strong government support. The Secretary of State was involved in the implementation of this program and was on the ground at the time. And we were located in a local hospital in Phnom Penh. Equipment was all donated from around the world, particularly Australia, and the surgeons visiting were self-funded. So this is a model of us sort of parachuting in to try and help a needy area that's very under-resourced with doctors. So what was good about this trip, that patients were pre-screened in the community prior to us trying to see them. So we only had a week. We made the most of it to try and do surgery with that week, and we had medical students and other local volunteers out pre-screening the patients before we arrived. So about 1,000 patients had already been assessed in the community and given bus tickets to come to the hospital if they'd been identified as having a remediable problem. We used medical students as translators, so they gained something and learned from us, and did about 250 surgeries in a week. There was great team spirit, lots of enthusiasm, and the hospital facilities that were basically, I think, rented from the local hospital were pretty good. So this is the theatre there. So what could have been better was perhaps the team composition. There was a lot of enthusiasm to all come and help, but there was a sort of mass invite of UK and Australian doctors, and we ended up with a team of 10 doctors, but didn't think, there were no nurses brought with us, and we found that we couldn't use local scrub nurses. There was also a bit of lack of preparation, so a lot of us arrived not really knowing what to expect. And for one individual in particular, there was significant culture shock from our pediatric ophthalmologist, who really became very overwhelmed of seeing so many blind children that she couldn't help because of the circumstances she found herself in. Also, we only brought one person with significant SIX experience, and having 2 phaco machines only, that meant that surgical capacity wasn't as good as it could have been. And we were unfamiliar with the equipment. The people mainly doing the cataract surgery hadn't used the particular machines that we had before. There was also the group dynamic, which was probably inevitable of traveling with a group of people that hadn't worked together before, but you may have seen this model of groups forming, then having to learn how to work together, and only reaching a level of peak performance after a while of working together. And we felt we were only just reaching that performing stage by the end of the week, and it was time to go home. So one solution to that may be to reform the group for further trips in years to come. So what else went less well? Even with this bus ticket scenario, lots of patients just deluged us who just heard by word of mouth that we were coming, and we found it very difficult to keep to just treating the people who'd been pre-identified. And lots of children were brought in. It's understandable, but there was a certain amount of opinion shopping of patients who'd already been seen by previous doctors and told that unfortunately there was nothing that could be done. They all came back again for second opinions, and it actually used up quite a lot of time that we didn't really have. There was a certain amount of tension with the local ophthalmology team, who were worried that we were taking patients from the city. The agreement was that we would take rural patients who couldn't afford other treatments, but the local doctors still seemed to be worried that we were taking funding from them, taking their paying patients from them. And there was a lack of interaction with other NGOs. There's several other ophthalmic NGOs working in Phnom Penh. And to me, it seemed like the people running our group hadn't really corresponded with the others, because, for example, as an oculoplastic surgeon, I did an evisceration for a child with a tumour in his eye, and was told that there were no implants available in Cambodia and no ocular prosthetics facilities. When I subsequently met one of the doctors from the next door hospital, they told me, oh yeah, no, there's another charitable hospital that has those resources, but we just didn't know about it. And the pharmacy situation, that there was no pharmacy available to us, and that we brought some of our own post-op medication, but we weren't really aware that we weren't going to be able to prescribe medicine in the way that we hoped. So Surgical outcomes, again, what went less well is it was difficult to phaco without having trained scrub nurses with us, so we'll bring them next time. Unfamiliarity with dense cataracts for some of the surgeons who came, and it led to a high PC tear rate that would have been, quite frankly, unacceptable at home. So it was also difficult to follow up the patients, so if they had a complication, they had to wait until the next group was coming a month or so later. And there was poor record keeping, so it was difficult to have medical records and be sure that the next group coming would know what had happened to those previous patients. The roles weren't always clearly identified. That when I arrived, I didn't really know what was going to be expected of me, and we had a couple of us had to spend a couple of days sort of managing roles and who was going to do what. That could be improved. The patient flow was very bad, just with people queuing outside the hospital and trying to work out who was coming where for what. And we were sparsely equipped. So what can improve would be more balanced teams next time, that they're building their own premises, which will make life a lot easier and can help to control the patient flow. Trying to build some links with the local professionals. So because of the slight tension with them, they didn't allow any of their registrars to come for any training with us, which was a real lost opportunity and which we hope will improve for next time. And also to target some of the invites to make sure that every group brings a sufficient number of 6 trained surgeons. I think returning teams to come who've worked together before, and hopefully maybe to have electronic patient records and work towards more local training. So my second briefer case study, teaching oculoplastics in China. So these trips that I've been on are run by a charity called Lifeline Express, which I think works in India as well. They have a model of strongly of training local surgeons to do cataracts. So they have 4 eye trains that travel around China training phaco surgery. They identify centers of need. The government then donates the cataract machines, and the surgical trainers come on a train with the cataract equipment, train the locals how to do the cataract surgery, and then leaving a phaco machine behind for them to use. This has been very successful and is now totally self-sufficient, so that all the trainers are now Chinese. And they've moved on to phase 2 for the visiting consultants, which means that we now just come purely to provide some training and education. Sorry, was that a question? No. So I've been twice, firstly to Mianyang in Sichuan province, and secondly to Yulin in Guangxi. So basically this is following the philosophy of you give a man a fish, he eats for a day. So you come in and do surgery, you're only benefiting the patients that you do the surgery on at that time. Whereas if you teach somebody to do the surgery, they can then provide ongoing surgery in their country. So over a 3-day trip each time, what we did was teaching, basically. We did lectures. They gathered ophthalmologists from around the regions for us to do some lectures for. We ran discussion groups, got the local juniors to do case presentations. We did videos. We had clinic-based teaching and surgical teaching. And one of the good things about this was engaging people in new teaching methods. I think partly because of the communist system in China and the very, very hierarchical system, trainees were not used to asking questions, involving themselves in discussion groups and really interacting. So some of these interactive teaching sessions were great. Oh, time out, she says. Okay. Shall I wrap up? Okay, so yeah, what I really wanted to do was compare and contrast some of these trips with what we'd done in Indonesia, which was to run a Training the Trainers program. So the third case study I was going to give an example of was going somewhere where really they needed support in learning how to facilitate training throughout their country. Moving on to the philosophy of not just teaching somebody to perform surgery, but to teach the locals how to teach people around their region, and this concept of cascading out the training. So we did a project running a 3-day Training the Trainers course in Indonesia twice, based on a model that the College of Ophthalmologists of the UK had done in Africa. I don't have time to go through all of it, but basically it had really good impact of trying to help the local trainees and the local trainers to get involved with some more modern teaching methods and basically improve their training locally. Okay, so I think I haven't got time for all of this, unfortunately. So what I was going to conclude in terms of what I've learned from these trips is that firstly, preparation is key. If you're going to go for a short time, you need to be as impactful as possible. You need to bring the right team with the right equipment to do the right job. You need to have local engagement if you're going to make any ongoing impact, and you need to train towards local sustainability rather than just promoting a sort of voluntourism. Thank you.